Hello everyone, we're going to talk about disseminated tuberculosis imitating hematological malignancy about a case. So this is a review of a case that we had in our hospital, and I would like to present it to you guys because it's very important. First of all, to know the definition and make a review about existing literature of disseminated tuberculosis, because in our patient, it was, at the beginning, it was mimicking what we thought it was an hematological presentation or malignancy, but then we ended up making our diagnosis as a disseminated tuberculosis. So I would like to begin explaining the definition of a disseminated tuberculosis, which we know there has to be 2 or more sites of infections, and they have to be non-contagious hematological disseminations of Mycobacterium tuberculosis. It can be caused by 2 ways or 2 paths. The first one can be a progressive primary infection, or it can also be by a reactivation of a latent focus with the subsequent spread. As we know, it's a life-threatening condition, and diagnosis can be very challenging due to 2 reasons. The first one, the main one, because it has non-specific clinical presentation, and the second one, but not least important reason, is because there is a lack on the tools that we use to make a laboratory diagnosis. So our objective, or our main goal from this article, is to make a review, like I said, of the existing literature of disseminated tuberculosis, but also to highlight the importance of making an early diagnosis, because early diagnosis can help us to make a diagnosis or think about disseminated tuberculosis in the early examinations, and therefore make an early diagnosis and start an early treatment for our patients, and therefore have a better outcome or have a better prognosis for them. So I would like to present our case. Our patient, he is a 77-year-old male that when he came to our hospital, he had begun 2 days prior to the admission to the ER with hyperexia, dysphagia, nausea, and vomiting of gastrobiliary content. In addition to knowing or referring that he has lost more than 10 kilograms in the past few days, he was presenting asthenia, adynamia, and fever quantified in 39 degrees. Which was referred by his family to be mostly during nighttime. Once he was admitted, we checked his vital signs and everything was stable. He was presenting jaundice and consumption syndrome data. Both intra and extrahepatic cholestasis were reported, as well as leukocytosis and acute renal injury. So at the beginning, we started an antibiotic treatment, thinking about possible cholangitis. So we started piperacillin with tazobactam. After we make an ultrasound, the report was referring to splenomegaly with probable metastasis nodules versus a lymphoma infiltration. So after we did serologies for HIV, HCV, and HBV, they all were reported negative. So we moved forward to the CT scan, which was reporting, like I said before, hepatosplenomegaly, vesicular lithiasis with added inflammatory and infectious process, ascites, bilateral pleural effusion, in peripheral. We after that did a peripheral blood smear and also an aspiration of the bone marrow, without any evidence of malignancy. So that's when we started questioning and trying to go a little farther for that. We make a bone marrow biopsy, and after they did, they made a spread. They reported neoplastic marrow infiltration. We also did immunohistochemistry, reporting CD20 positive, Ki67 positive, and CD3 negative, which was compatible with the lymphoproliferative neoplasm, and therefore we moved forward to doing endoscopy, which in this patient was reported as normal. We found out negative tumor antigens were also noted, and due to discordant results between the infections and neoplastic process, we had to do a myeloculture, which once it was performed from the bone marrow, it reported resistant alcoholic acid bacil and reactive hyperplasia of the 3 hematological cell lines, reticulating fibrosis grade 1. So in conclusion, disseminated tuberculosis it's an important health problem, not only in Mexico, which is endemic for tuberculosis, but also around the world. And we know it's associated with a significant burden of morbidity and mortality. Patients from endemic areas who present with prolonged pyrexia of unknown origin, weight loss, hepatomegaly, splenomegaly, liver function abnormalities, and abnormal hematological. It can be a clue and should be targeted resolute efforts to make a diagnosis and a properly treatment, and specifically in early treatment to have a better prognosis of these patients. Thank you very much.